Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders. I'm Chris the Chimanchu, and I'm here with our wonderful other Cribsiders, Dr. Sam Mazer and our producer, Dr. Angela Jang. How are you guys?
Fantastic. Thanks for asking, Chris.
Doing great. Really excited for this episode tonight.
So tonight, we are having our first of two episodes with Dr. Jordan Simmons, and tonight he's going to talk about acute hyperkalemia. But first, let Sam remind you what the show is about.
Sure. We are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
Today we'll be talking to our fantastic guest, Dr. Jordan Simmons. He is Professor of Pediatrics at the University of Washington and attending nephrologist at Seattle Children's Hospital. He got his MD from Columbia University, completed a pediatric residency at Children's Memorial Hospital in Chicago, and fellowship in pediatric nephrology at Children's Hospital in Boston. Dr. Simmons' area of clinical interest is in renal replacement therapies and acute kidney injury. He's Center PI for the Prospective Pediatric Acute Kidney Injury Network, a multi-center consortium investigating the causes and treatment of pediatric acute kidney injury. Dr. Simmons' other major area of academic interest is in medical education. He serves as the program director for the Pediatric Nephrology Fellowship at Seattle Children's and as co-director for pediatric education at the University of Washington. Having worked with Jordan before, I can say that he is so detailed and very thorough and so excited about teaching. We can definitely see that, and I'm so excited to have him as a guest on this show. Today, he'll teach us about cardiac myocyte activity, normal levels of potassium, and managing acute hyperkalemia.
I cannot wait to get into some high potassium content.
Oh, yeah.
Yeah, like the Kool-Aid man. Oh, yeah. And we are back to the Cribsiders. We have a wonderful guest today. We have Dr. Jordan Simmons. How are you doing?
I'm well, thanks. How are you? Thanks for having me on today.
We really appreciate you being on our show. Now, we're an informal group, so I just want to first ask, is it okay to call you by your first name?
Oh, yes, please do. Absolutely. Dr. Simmons was my dad, and I don't need that stress. So, yeah, it can be better this way.
Excellent, excellent. So we're just going to start off with a couple rapid-fire questions, to get to know you better, as a little bit of a warm-up. Do you mind just giving us sort of like a one-liner about yourself? Hopefully include something that's non-medical.
Sure. So my name's Jordan Simmons, and I work at Seattle Children's Hospital. I'm one of the nephrologists here. I take care of kids with all sorts of kidney diseases and do a lot of other stuff with medical education too. So that's another fun thing that I enjoy doing. And fun personal fact about me is that just 6 months ago, I became a grandfather for the first time, and it's really been a load of fun. I'm here to tell you.
Congratulations. And
Thank you very much. Yeah. He's perfect.
Yeah, that's a huge life milestone.
It's wonderful. Yeah, and we're lucky. Our kids live here in town in Seattle, so we see the baby a lot. It's really nice.
That was going to be my next question. It's so great to have grandparents around close by, and it's such a great time for the kids to be growing up, and once you miss it, you miss it. So that's awesome.
Yeah, thank you very much. Appreciate it.
Well, now my next question feels kind of like a little bit of a downer, but. I always like to ask this is what's your favorite failure and what did you learn from it?
My favorite failure, it certainly wasn't a favorite when it happened, but it was probably this final term paper that I had to write when I was an undergraduate. Actually, my undergraduate degree is in history of art, and I was taking an art and architecture course. And I waited a little too long to get to the paper and wrote it in a relatively short period of time, but I thought it was okay. And I turned it in, and the TA who did the grading just savaged it. She really hated it. And I still remember the last line of the comments, which were quite extensive. And in the end, it just said, "This is a very sketchy, simplistic paper, D."
Ooh, that's rough.
Yeah, it's okay. She probably was right. It was Maya Lin, actually, who you may know. She designed the Vietnam Veterans Memorial, et cetera, et cetera. Oh. And so she knows from whence she speaks. And it probably was pretty bad paper. So what did I learn? I guess I wasn't meant to be a scholar. And so that's okay.
I was
Thanks,
going to
Raquel.
say, it's all subjective and you bring your perspective to it, but to have something like that graded, I feel like maybe we could say that she knew what she was talking about.
She totally knew what she was talking about, and maybe she sent me in the right direction. So she's a much better architect than I am, that's for sure.
We always find that, a lot of those lessons are you got sent in a certain direction that you didn't exactly see coming at a certain time, and here we are, X number of years later, and quite grateful for that experience. And so I feel like that's a theme that we're getting a fair amount when we ask this question.
All works out in the end.
Hey, Cribsiders listeners, let's talk some more about Freed. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. So here's the backstory. Gabby, a family medicine physician, and Erez, a computer engineer, came up with Freed, a solution that could help alleviate the daily burden of overworked clinicians everywhere. And for Erez, selfishly, it could mean that he would spend more time with Gabby, who was spending nights, weekends, and holidays updating medical documentation. So what does Freed do? Freed turns clinicians' daily workflow into accurate documentation instantly. There's no training time, no onboarding, no extra mental burden. All the magic happens in just a few clicks, so clinicians can spend less energy on charting and more time on what they do best. Today, more than 4,000 clinicians and their spouses have fallen in love with Freed. So Freed is this AI scribe that makes charting go away, doing your soap notes for you. It is HIPAA compliant, takes 30 seconds to learn, and costs only $99 per month. But you can try Freed for free right now by going to freed.ai. That's freed.ai. And listeners of Cribsiders can use code CRIB50 for $50 off their first month. Hey, we have so much stuff going on in this case. We all want to learn about hyperkalemia. I was just going to skip the next question. You can see I'm already moving on to the next thing, so I'm so sorry for everybody who's listening. I'm just going on rapid fire here. But Angela, if you want to jump into the next case, let's just get going so we can talk about some potassium.
Yeah, absolutely. So in your first case, you are in the Cash Children's ED, and you're seeing an ex-term, previously healthy 9-month-old who was sent over from their PCP for pretty severe faltering growth. At 7 months of age, they were in the 50th percentile, and now they're at the 7th percentile. And they're feeding kind of all the time, but they're not really tolerating it, and they're more tired, maybe a little bit limp. So you draw some labs, and there's no leukocytosis or anemia, but then you receive a call from the lab for a sodium of 122, a chloride of 88, a bicarb of 17, so metabolic acidosis, but more importantly, a critical potassium of 7.5. So I think I wanted to talk about, this set of electrolytes a little bit. They're all a little off. A little might be an understatement, but why do we worry about potassium the most in this acute setting?
Yeah, I think that, I think there's a lot of things to consider here. Everything's a little bit off, and it sort of calls to mind some particular problems and patterns which we could think about. It's interesting that there's low sodium, a metabolic acidosis, and hyperkalemia all combined at the same time in a patient, an infant who's acting kind of sick, and sort of makes one feel that there might be some defect in mineralocorticoid function, which could potentially unify all the findings, and then you can get to what sort of diagnosis might go there. But your question is, why do we really care about hyperkalemia? And potassium, the thing that we are taught, all of us, early in our training, and that we remember all the way through, is that hyperkalemia is bad for your heart. And that's probably the big red flag that everybody carries around in their mind. That's why every red light in the lab goes off when the potassium is elevated. That's when you're always getting calls from the lab and from the nursing team at the bedside if they get those results before you do. We have to take hyperkalemia very seriously. The normal job for potassium is to maintain a resting cell membrane potential for nerves and for muscles. And when potassium in the plasma becomes elevated, the cell membrane becomes more excitable, and you can have changes in that normal depolarization, repolarization phenomenon that you're supposed to have well controlled in nerve cells and in muscle cells. The one we care about most of all is in the heart. So every medical student is taught very early that hyperkalemia can lead to arrhythmias, and that's the thing that we worry about most of all. So I think if you look at those lab tests while you're going to be thinking and potentially worried about everything, the biggest red flag will probably be with the potassium level, because it's quite high.
Okay. And speaking of, it is high, but what are your kind of cutoff ranges for high? And then you could throw in low too. And then does it vary by age? This is a 9-month-old.
It does, as it turns out. So, the standard sort of definitions for hyperkalemia are usually written in the norms within the lab. Anything above 5.5 is usually considered to be an elevated potassium level, and so that usually gets the label of hyperkalemia. Do I worry about it if it's 5.6 or 5.8? Not in my nephrology world, and we may get to that a little bit later. If you hang out at those levels chronically, it's probably less of an issue than if it's something that happens very, very acutely. The lower level of normal is usually around 3.5 milliequivalents per liter or millimoles per liter. Either one of those units makes sense for potassium, a univalent ion. And we sort of think about normal in there, too low being less than 3.5, too high being above 5.5. I think it's important to remember also the way the potassium normally distributes, which informs us about what those normal values are supposed to be. So those are really low numbers compared, for example, to like sodium, which is 140 milliequivalents per liter on a blood test. But those numbers reverse exactly within cells. Most of the potassium in our bodies is within the cellular compartment, and the potassium level inside of cells is about 140 milliequivalents per liter. So that's really where most of the potassium lives in our patients. And maintaining that equilibrium and that gradient between what's inside of cells and what's outside is what maintains that cell membrane potential, and those small changes are going to be what puts you in potential risk for cardiac arrhythmias and other problems. Does it change with age? It turns out most kids have the same potassium level that most adults have. So those are pretty much the same, and the outlier are infants. And it turns out that infants tend to run slightly higher potassium levels than older kids and adults do. This is thought to be related to some maturational changes in kidney function that happens over time. So when a baby's first born, their glomerular filtration rate, GFR, is not completely optimized yet, and it takes a little while for things to move forward. So you're not really losing potassium as fast as you would. And their renal tubular function and response to aldosterone, which is going to be the hormone that tends more than any to manage potassium, their renal tube is a little less responsive. And so infants tend to have slightly higher values. I've always wondered if it's actually because of the way that we draw the blood test, but the teaching is that their kidneys are just a little bit different. And as they mature, and I'm not quite sure where the transition period is, but you end up seeing pretty much the same potassium levels through most of childhood into adulthood.
And now I get a question you were mentioning as we talk about the action potential between these cells. Obviously, the cardiac myocyte is the one we care about the most because an arrhythmia runs to be a major problem. And generally speaking, when you're already having that arrhythmia, that's where you don't want to be. You want to kind of be there ahead of time. So you hopefully are in this asymptomatic hyperkalemia state. I was wondering how the action potentials work for the other kind of muscles in the body, for example. So like what type of symptoms should we be experiencing when we have hyperkalemia, and or is it universally asymptomatic, or we should be seeing people who are asymptomatic?
Yeah, your point is really well taken. I think the majority of patients are going to be asymptomatic with hyperkalemia. I think we find it on a blood test. Maybe we were thinking this is a possibility. Maybe it's one of my renal patients who we know has a problem with potassium excretion because the renal function isn't so great. And you're like, gee, that could be something that's going on here. Other times it's a surprise, and we end up finding it on a screening test. We end up finding it on our inpatients on the ward, or maybe in the intensive care unit. We might worry that some of our patients are at greater risk, but usually that's when we find it, and it tends to be the patient. It tends to be asymptomatic. A symptomatic patient is obviously much more worrisome, and because of the impact the potassium has on action potential and muscle function, not just at cardiac muscle, but on skeletal muscle as well, you can actually have either with hyperkalemia or hypokalemia muscle weakness. There's this very unusual disease process called periodic paralysis, hyperkalemic periodic paralysis, where because of an abnormality of a sodium channel in muscle that doesn't close as efficiently as it's supposed to in that sort of open-close phenomenon that happens, potassium is able to leak out of cells. Your patients get hyperkalemic because of this genetic defect, and they will have intermittent episodes of muscle weakness. So if you're meeting a patient and your patient has muscle weakness and maybe even has paralysis, not high on most people's differential is going to be hyperkalemia, and it should be, because if your patient is already having muscle weakness, they may have very high potassium levels, and their risk then for the next step of being a cardiac arrhythmia could be higher for them.
So I get to ask the big question. We already started talking a little bit what some causes, we've touched briefly on them, some causes of hyperkalemia. I was wondering if you could sort of help us and our audience break down some of the large buckets of causes of hyperkalemia, even include maybe some of the reasons that we may have false hyperkalemia, pseudo hyperkalemia.
Yeah, absolutely. No, I think hyperkalemia is an important phenomenon to consider. You tend to be very trusting of numbers that show up on a computer. After all, you had to sign in and there's a password and it's all very sophisticated. And all the numbers have these colors and like arrows on them, and they are supposed to be telling you things. But it's not always the truth. It may be the truth in the lab, but it may not be the truth inside of your patient. So I think that's important. And I think that's true with whenever we take care of our patients, a tiny little bit of skepticism and having, understanding your index of suspicion helps you do the right thing for your patient rather than having premature diagnostic closure and going down maybe the wrong route. So I think that's important all the time. In hyperkalemia, we know that the lab test may read high when actually the blood inside of the patient has normal values. And the most common reason that we see this is because of breakdown of cells, usually red blood cells, when we obtain the blood test. So, the smaller the needle, because the smaller the patient, the smaller the vein, you're going to be more likely to have some damage to cells. And red cell hemolysis at the time that we draw the blood test is probably the most common reason that we see what we would call pseudo hyperkalemia, high potassium on a lab test or in the blood tube, but not actually inside of the patient. If you draw blood from a heel stick or from a finger poke, it's a little bit more likely that red blood cells can break apart. I actually think there's probably always a little bit of hemolysis. You can call the lab and they'll mark it and they'll say there's marked hemolysis, but there's probably always a little bit, especially when we're drawing blood out of really tiny little people. And there's some other circumstances that you can get pseudo hyperkalemia, even if the blood draw was a good one. And the most commonly reported times are when the patient has very, very high platelets or very, very high white blood cells. Because, again, potassium is an intracellular molecule. And if those cells within the tube that you've just drawn are particularly high, during the time that the tube transports to the lab, those cells might break down. And if they break down, they probably all break down a little bit, but if you've just got more of them, you'll release a little bit more potassium. It usually is not enough to go from a value of 4 milliequivalents per liter, which is normal, up to 7, which is going to scare everybody. But you can get a little bit of an increase. And so the most common reasons for pseudohyperkalemia, definitely are going to be hemolysis on the blood draw when you're obtaining the blood, or maybe related to those high numbers of cells in the tube.
I was actually wondering, sometimes I definitely have this moment where it comes back and you get called and everyone is freaking out. And then the comment on the lab will say kind of mild hemolysis, marked hemolysis. Do I just say this test is inaccurate, or can I maybe adjust the number by, a unit, 2 units, depending on the level of hemolysis?
Yeah, I don't think it's a really good question. And I think that I don't feel that I can look at an adjective like mild, moderate, or marked and know how much of a change that's going to give me. I think I'll just know that it's not as high as it seems. And then I have to ask myself, am I worried or am I not? And then you have to think about the safety of your patient. So if the number comes back 8 milliequivalents per liter and there's marked hemolysis, if it's 7.2, that's still pretty high. And so I think my index of suspicion is going to be higher and I'm going to be a little bit more worried. If it comes back at 6 and there's a report of some hemolysis and I know it's a small child and I know it was a difficult blood draw, I know it was a heel poke, because sometimes I'll ask the parents about that, maybe I'm less worried. And at least in my world also, I might actually let that ride because I know that that's a patient who's usually hanging out at around 5.8 and I'm really not too worried. So I think it is necessary to consider context and not make any assumptions. There are times when we can say it'll probably be okay, but I always tend to teach that if you hear yourself saying it'll probably be okay, it probably won't, because you're trying to convince yourself of something. And it's usually better just to make sure. So what do? We tend to repeat the blood test, and repeating, I think, is necessary because you really want to get a sense of what's going on. One of the challenges, I think, is time lag. And so then you have to repeat and you have to ask yourself, do I need to prepare to do things, or is it okay to repeat and reassess after I get my values back? And again, a lot of that is context related to what do I know about this patient? What do I know about what might be going on with them? And how does that help me decide what choices I'm going to make?
Awesome. So yeah, this is a little bit of a derail from our differential diagnosis question. So we kind of hit all the iatrogenic pieces with elevated white blood cell, any essentially cell that could break down, any cell that gets sheared by any device with which we collect the blood. Is there anything else iatrogenic, or should we jump into some of the rest of the?
No, I think definitely, yeah. And I may just, if I may, I think maybe iatrogenic is not the best term right here.
Only
I'll
you're totally right.
I'll say that it's pseudo hyperkalemia. It's not real because it's in the tube and it's not in the patient. Because weirdly, there are some iatrogenic causes for hyperkalemia, things that we do to patients, which maybe we wish we hadn't. And I think that is part of the differential diagnosis of what's real. So if you think your patient really has hyperkalemia, you have to think about what the possibilities are. And I think there are three main buckets to put it into. One is the iatrogenic one, which is actually really uncommon, which is too much potassium has gone into the patient, more than their capacity to excrete. This is actually really very uncommon. If you've got normal kidney function, if you eat potassium, you just increase your excretion. If you eat a lot of potassium, you further increase your excretion. So there's an adaptation capability with normal renal physiology that just allows people to increase their ability to excrete potassium and maintain balance, which is pretty cool. But who gets in trouble? Rarely the patients who can't adapt to the increased potassium delivery are the ones who have slightly decreased excretion capacity to begin with because they have renal dysfunction or they're taking a medication which prevents their excretion, etc. And we as physicians can overwhelm the system if we give way too much. So if you really make an error in your intravenous fluids, if we really make an error in our parenteral nutrition, very high delivery of red blood cells and massive transfusion, which because packed red blood cells have very high potassium levels, levels that you wish you don't want to know about because they make my chest hurt just thinking about how high they are. Those are circumstances where we could overload a patient, and that would be true iatrogenic hyperkalemia. Can you eat too much potassium? Really hard to do because of the adaptation phenomenon, unless you have a decreased excretion capacity at baseline. So too much in is one potential cause. The next thing to think about is sort of problems of transcellular movement of potassium. Remember, like we said, most potassium is inside of cells, and it's supposed to stay there, and things are supposed to be maintained. We have this very nice sodium-potassium ATPase that is keeping the potassium in cells, sodium outside of cells, maintaining things the way it's supposed to be. And you can have problems where potassium will actually come out of cells. That could be a situation where cells are being destroyed. So we talked about hemolysis in the tube or when we're actually drawing the blood. You could have that phenomenon of cell destruction inside of a human being. So tumor lysis syndrome is probably the one that comes to mind for most people. Way too many white blood cells. They're cancerous white blood cells. And unfortunately, they're very delicate. They tend to break down, especially when we give chemotherapy to our patients. And that will release lots of intracellular components, including potassium. Cell necrosis or injury can also lead to hyperkalemia. So those are patients who end up with rhabdomyolysis or crush injuries, lots of cellular breakdown and release of potassium under those circumstances, which again can overwhelm the system. And rarely, very rapid hemolytic anemias could do this too. So those are all circumstances where cells are breaking down and releasing potassium into the bloodstream within the patient. The patient that Angela presented to us has a metabolic acidosis. So we know that patients who develop metabolic acidosis will have a translocation phenomenon where the theory at least, is that the excess protons that are inside of the bloodstream need to go places to be buffered, because if your pH drops to 6 point something, that's not so good for you. So the body has a lot of systems to try to maintain pH as close as it can be to normal. And one of the things it does is to send protons into cells where they can get buffered. And if positive charge goes into cells, you have to maintain electron neutrality. So some positive charge has to come out to sort of make room. And since potassium is the major intracellular cation, it will tend to leak out. So metabolic acidosis will tend to give you a hyperkalemia. And sometimes in patients who have metabolic acidosis, they've also got a little bit of renal dysfunction because maybe they're sick, their volume deplete. This particular patient showed up sounding kind of sick and maybe a little volume deplete. So maybe they also have an excretory problem. And we talked a little bit about periodic paralysis beforehand. That's another phenomenon where you've got potassium leakage out of cells. And then like the biggest bucket for hyperkalemia, either on the acute or the chronic side, is a problem of excretion. So most people will be able to keep their potassium where it needs to be. And anybody whose potassium is getting high and staying high probably has a problem with potassium excretion. So that's usually a low glomerular filtration rate, a low GFR. That can be in the setting of acute kidney injury or in chronic kidney disease or combinations of those things. You can have people with some type of dysfunction of their renal tubule, right? That's where all the business happens for getting rid of potassium. Potassium is filtered at the glomerulus, but it's actually all then reabsorbed proximally and then re-excreted in the distal portions of the tubule and the collecting duct. And so if you've got something like type 4 renal tubular acidosis, which is a sort of a low aldosterone state one way or the other, that will give you hyperkalemia. Infants, again, tend not to respond super well to aldo, so they'll tend to have that phenomenon. Interestingly, patients with sickle cell disease will over time develop renal tubular dysfunction as a result of sickling within the renal medulla. And so their ability to excrete potassium is a little bit reduced. Anybody who, one of the ways that potassium gets to the distal tubule is that, again, it's re-secreted in a collecting duct. But there needs to be enough urinary flow to allow that secretion to happen. So if you're not flowing, like a river inside the renal tubule, there's no place to send that potassium. And who doesn't have flowing urine? People who are volume deplete. So if you show up a little bit dry, you're not making that much urine, it's harder to excrete your potassium. And you need to deliver sodium to the distal tubule to make a sodium-potassium exchange in the principal cells in the distal tube, in the cortical collecting duct, rather. And if you don't have enough sodium delivery, you can't make that exchange. And who doesn't have enough sodium delivery? People, again, who are volume deplete, who are reabsorbing a lot of sodium proximally. If you've got low mineralocorticoid activity, that will also give you problems of excretion. So aldo is the hormone which tends to promote most of your secretion in the more distal portions of the kidney. So if you don't make it, or you make plenty of it, but your receptor doesn't work, or your receptor works, but you don't have the appropriate second messaging, or if you've got all of that, but your channels in the principal cells in the kidney are not functioning appropriately, then you can't engage in this phenomenon. That can occur in certain disease processes like congenital adrenal hyperplasia, where you've got a lack of mineralocorticoid. There's primary hypoaldosteronism, which is pretty uncommon in kids, but maybe a little bit more in adults in certain circumstances. There are these very rare genetic phenomenons of pseudo-hypoaldosteronism that you can see. So all of these phenomenon will tend to reduce renal excretion. And we know that there are medications that will also have an effect on those receptors or an effect on those channels, which will also tend to reduce excretion. So it's kind of a long talk, but there you go. It's, just to summarize it again, it's too much in, which is kind of an uncommon phenomenon, a shifting of potassium, which is a fairly common phenomenon, and a primary component of problems with potassium management, defects in potassium excretion in the kidney.
Chris, what do you think? I think that's probably the most complete differential that we've done in this entire show so far. So I want to give a round of applause there.
That was amazing. You just you did a full lecture in 10 minutes of every single cause of hyperkalemia.
With any luck, your audience is still awake.
Well, to be fair, I was about to summarize too, but you literally even hit the summary of the main points on top of it. So I literally have nothing more to say. So I guess let's hit the workup for this patient. So this patient comes in, we have this huge differential. We're thinking right now all we have is an abnormal lab test. So we have to say, hey, we're going to need some physical. We're going to need some other lab tests, maybe some imaging. Who knows? This is why we're asking you the big questions here. So now he's hit our emergency room. We've gotten this lab back. We got the phone call, critical, 7.5. What do you recommend that we do for a workup when we see hyperkalemia?
Yeah, so it'll depend a little bit, like we said earlier, about context. And there's this story, it's an infant, now is having faltering growth, has not just hyperkalemia, but several other phenomena which really look a lot like mineralocorticoid defect, either in amount or in ability to function. That's because not only is there hyperkalemia, but there's also metabolic acidosis. Remember, mineralocorticoid helps you excrete protons as well, the distal portions of the kidney, and helps you reabsorb sodium. And it's interesting, this patient happens to be hyponatremic too. So what do infants get that cause these problems? Congenital adrenal hyperplasia is something to consider. There can also be these genetic defects of channels, which will give you pseudo hypoaldosteronism. So those would be the things that you would want to think about. That's big picture stuff right now. You want to take care of your patient right now and make sure you know what you're dealing with. So what do you need to do? You probably need to repeat the blood test. You need to get a really good, trustworthy one, because if it turns out this little person was a tough stick, or maybe had a heel poke or a finger poke and people thought that was okay, maybe it's not. And you need to get maybe your best phlebotomist in there to make sure you can get a venipuncture and really get a good test on this patient so you can get something that's trustworthy, because we already spoke about the pseudo hyperkalemia problem, and you need to see kind of what's going on. So I'd repeat that. I'd repeat all the chemistries, because you want to see, again, can we confirm that there's a metabolic acidosis? Can we confirm the hyponatremia? You'll need to know what the renal function is. So if you haven't had a creatinine and a BUN, you're going to want to know what's going on there. This is a little person in our hospital. Our assay will probably give you a serum creatinine of about, 0.3 maybe for somebody who's this age. So if this comes back at 1.3, something's up. And clearly you're in a renal dysfunction bucket, as opposed to maybe an endocrine-related bucket. And so you need that up front. You'd probably want to check some urine. You'd want at least a basic urinalysis, because if the patient maybe isn't this infant, but is an older child, and it turns out that they've got a whole bunch of hematuria and proteinuria, maybe they have glomerulonephritis and their GFR is low. On that basis, you'll see the creatinine is elevated, and they, were at home eating a lot of bananas, which isn't supposed to cause a problem to eat too much potassium. But if your renal function is poor, maybe you could. So maybe that's what's going on here. And if you're able to get urine, you'd probably want to send that urine also for urine electrolytes, sodium and potassium, so that you can do some calculations. You'll need a creatinine and an osmolality as well. There's a whole bunch of math you can do, and it's really nerdy math, and we nephrologists love it. And it's probably why I've got job security, because we like doing that stuff, and so we can help out with that. One of the challenges, I think, with these patients when they're in your emergency department or when you're first meeting them is a lot of time they're volume deplete, and they're not going to make any urine for you, but you're going to want to get it if you possibly can. It's reasonable to get a CBC while you're at it, I think, because if the platelet count is 1,000 or if the white blood cell count is 200,000, something's going on that's different. And it would be interesting if the first clue to a leukemia were that the patient was hyperkalemic. So I think it's worth checking that. And then you get into some weird stuff, right? So we're a little worried this could be an endocrine phenomenon. So is it time to check aldo levels? They won't be back for a week, but here's a chance. You could start. And all those endocrinology tests that you're going to do, whether it's aldos or renins or some other set of tests that our endocrine friends want us to get, they're the most illuminating when the patient is most perturbed. So when all the other stuff that it's supposed to be managing is the most out of whack, you'll really know if the system is able to keep up or if it isn't. If this were a patient who were in an automobile crash or it had some sort of work-related crush injury, you'd want to know about rhabdomyolysis. You'd probably check out creatine kinase at that point. I think those are all things that we would want to be looking for, because what are we doing? We're looking to see if there's any evidence to tell us whether there's been translocation back and forth. And we're looking to see if we can demonstrate any evidence that will show that kidney excreting capacity for potassium is diminished, and those things aren't mutually exclusive. So that's the broad net I think we would throw at this point.
And so just to summarize a little bit, and then I have one question, but it sounds like first line pass is going to be CBC, renal function if you don't have that already, urinalysis, urine electrolytes, and those are kind of the big pieces for the first line. And then we're talking about things that we have based on history. Before we get into the history, the urine electrolytes, I know you said, hey, we could do the nephrologist can do some math. We here are hoping that we can learn. And what math are we doing? What are we looking for specifically? Are we looking for a FeNO? Are we looking for something else? Just take us through that piece if you would.
Yeah. So if a patient is hyperkalemic and their urine potassium is low-ish, then that's weird. And it just shouldn't be like that, right? You should be excreting more. So urine potassium less than like 20-ish milliequivalents per liter, give or take, is probably lower than it should be. When it gets above that, then it looks like the kidney is trying, but the question is its capacity diminished? And that's where some calculations can occasionally help you out. You can do potassium to creatinine ratios. People sort of argue as to where the numbers are supposed to be. There's this interesting piece of math called a transtubular potassium gradient, or a TTKG, that you can use. People again argue, is it really as accurate as we used to think it was? It's kind of a slick tool. If it gives you the right number, you can feel good about it. If it doesn't, you say, well, it's not really a good test anyway. I never believed in it. So you're allowed to swing it either way that you want. But occasionally when patients are really very hyperkalemic, you can use those tests as markers of the fact that it really is the kidney that is not doing what it's supposed to do. And then you have to ask why. A urine sodium that's very low will suggest that the patient might be intravascularly volume deplete. They're trying desperately to hold on to sodium to fix their volume status, and there's not enough distal delivery of sodium or maybe just urinary flow to make the exchange. That's a patient who, in addition to other things, you're going to need to volume expand them. And you maybe know that already based on your clinical judgment. You look at the patient and we know by an exam that the patient looks volume deplete. So you've probably already given your bolus of isotonic crystalloid anyway at that point, and that's very reasonable. And if you volume expand these patients, they can pee. And if they can pee, they can maybe get rid of their potassium. So I think that works in the right direction. So the urine testing would be a urine sodium to see if it's low. Maybe you're volume deplete, maybe you're not excreting appropriately. A urine potassium to see if you're getting rid of potassium or at least trying to do it. And never send urine anything without sending a urine creatinine because you need it for the math.
Along with the blood tests, are there any imaging tests that you think you should always get off the bat, like a bladder scan or something like that?
Yeah, no, that's a really good question. I think that I don't really think about doing a bladder scan, but that's a very reasonable question. You know, I've got enough gray hair that I spend some time also, percussing out bladders to see if they seem to be really big and really full. But yeah, bladder scan's a great tool to check and see. Are patients who have urological abnormalities who become obstructed at the bladder outlet, maybe they're not fully obstructed, the parents think the kid is still making some urine, but back pressure from the bladder upwards into the kidney actually leads to renal tubular dysfunction. It can give you something that looks a lot like a transient type 4 RTA. If you can relieve that obstruction, not only will the kid pee, not only will the creatinine come down, et cetera, the potassium will come down, and the acid-base problems will also tend to fix themselves. That's not unreasonable. If you do a renal ultrasound and you're like, whoops, there's only one kidney in there, or there's undiscovered bad hydronephrosis, and the patient has actually been obstructed for years, and I had no idea, it obviously doesn't apply to this patient who's an infant, you may learn something. I wouldn't worry too much about ordering the stat ultrasound right there. I'd stabilize my patient first. Maybe that's a second line imaging study that you can think of. There is a test, though, that you probably should do right away, and that's an electrocardiogram. And so that's moving beyond what blood tests you need to do, because we've already talked about sort of the primacy of cardiac function in the setting of hyperkalemia. And if you're not sure what you got, you probably should get an electrocardiogram and make sure that the patient doesn't have any signs of arrhythmia, which heightens our concern. And we got to get in there then.
Can we just do an EKG refresher? Actually, I discovered this is like my worst topic in residency is what are we, besides like an obvious arrhythmia, what are we looking for on the EKG? We hear about peak T waves. I heard sometimes it's normal in kids. Like,
yeah,
how do you think about that?
I'm a terrible electrophysiologist, and I'm very glad I have cardiology colleagues who can do this way better than I can. So I'll admit, with that caveat, um, the cutesy poo little rhyme that I was taught a long time ago was peak your T's, lose your P's, widen your QRS. So that's the way I learned it. And so peak T waves is supposed to be one of the earlier signs of hyperkalemia. It's not tall T waves, it's peaked T waves. So they're actually, sometimes people say pinched. So they're kind of narrow at the base, not wide. And it tends to be kind of pointy at the top. Rather than sort of the rounded ones. Teenagers, actually teenage males, I think, are the ones that tend to have slightly higher T waves with a broader base and kind of rounded at the top. And that can be normal for them. But again, I'd ask the rhythm docs about that one just to make sure that I'm saying the right thing. So peak T is supposed to be the first thing. It's supposed to be relatively narrow at the base, kind of pointy at the top. P waves start to do some funny things, and as hyperkalemia advances, not only do they become shorter and shorter, eventually you can't really see them very well, and then the QRS complex tends to widen, and at its most severe, a very wide QRS and a very peak T wave can look like sine wave curve, and that's the thing that you're worried about most of all. So, all that said, if you look at an electrocardiogram and you don't have somebody who's really good at it who can help you, treat it with respect and err on the side of saying we got to keep a person's heart safe. So I think erring on the other side and making a mistake in that direction would not be a mistake we'd want to make.
I feel this is a good time to talk about maybe acute management, since we've done the workup, and at the same time, if you have a 7.5 confirmed potassium, you probably should also be thinking about management. So there's several phases of this, but what is the most immediate rapid onset management for this potassium level?
So if you're really worried about a patient, and again, one of the questions which we've alluded to is when do I really have to worry? I would say that if the potassium is elevated, most people say if it's above a number like 7, you should be worried. If it's around there and the patient is having some of those symptoms that we talked about, the muscle weakness and other palpitations, which might be an early sign that there actually is an arrhythmia going on, you need to have a much higher level of concern. And so also for a patient whose potassium level maybe isn't quite that high, maybe in the 6 range, but they're at risk for that potassium to continue to go up. That would be one of my nephrology patients who has really poor renal function. They're not going to be able to help us out under those circumstances. So that's a patient who's at risk. You've discovered that the patient has a new onset leukemia with an exceptionally high white count, or this patient has just sustained a crush injury and they're going to continue to leak a lot of potassium. We've caught this maybe on the upswing. So even if the potassium's only in the 6 range, which is supposed to be high but maybe less worrisome, those are patients where your index of concern is going to be a lot higher. So if you're in this high index of concern sort of range, the first level of concern is going to be about what's happening with the heart, and is the heart at risk for an arrhythmia. So I think one of the classic lines every medical student hears is you need to stabilize the cardiac membrane, and so that's where calcium infusion comes in. And you always ask, what does calcium do? And people respond, calcium stabilizes the membrane. And my question always is, yeah, but why? So, because I always like to understand the why. And it has to do with that relationship of potassium levels on the extracellular side and calcium levels. And it's the relationship of calcium to potassium, which actually tends to stabilize or trigger action potentials around the cardiac membrane. And the sort of depolarization, repolarization phenomenon has to do with channels that open and close in very specific organized manners, where potassium levels go up, go down, calcium levels go up and go down. And so if your potassium level is too high, if you actually raise the calcium level closer to the normal relationship between those two ions at the cell membrane, it's less likely to fire and do something funny. And so that's the reason, if we can't bring the potassium down quickly, because that sometimes takes time, you can rapidly raise the calcium level, and that's what we're trying to achieve there. So we have a low threshold to give calcium to our patients for that purpose. Intravenous calcium is not without its own risks. If anyone's ever seen a calcium burn from a leaky IV, they're terrible. A lot of skin will slough right off. It's really bad. So you have to be very, very respectful of this drug and try to get your best IV person to put in the best IV so you can be pretty confident it's going to go right in. Calcium gluconate should be a reasonable drug to use. Calcium chloride is also very effective. It tends to ionize a little bit more completely and maybe a little bit more quickly. So our ICU friends really like it. It tends to be used in the setting of the patient who's gone too far, who's maybe had an arrest. And if you have central access, like we often have in the intensive care unit setting, that's a nice reason to use calcium chloride. But either drug will work. And again, you're trying to get things better. You're not looking to hit a number. You're looking to just improve that phenomenon. So first step always is to think about the cardiac risk and try to get the heart into a more stable place. So that's where the calcium infusion is going to come in. That's really first line.
And will we see, for example, will you see an improvement in the peak T waves giving calcium, or are you going to have to wait till the actual potassium is better? Like, you say, hey, do we just give the single dose, whatever our, Lexicomp formula is? I apologize for the brand name there. And, or do we, look for something on EKG?
That's a good question. I don't know the answer to that. And I think you can see some improvement, but I don't know if you would absolutely see it. And it's never one step, because when you're giving your calcium to try to make things safer from an arrhythmia risk standpoint, you're also doing things to try to reduce the potassium level inside of the patient's bloodstream so that the potassium level at that cell membrane is going to come down relatively quickly. And so then the question is, what can you do to bring that potassium level in the bloodstream, which the one that the heart membrane is seeing? What can you do to bring that down relatively quickly? And the answer is that making the potassium leave the body usually takes a little longer. So a lot of times what we have to do is we have to push it someplace else. And so we talked about the idea that potassium can leak out of cells, for example, in the setting of metabolic acidosis. And so what we need to do is to try maneuvers that will push potassium from the bloodstream into cells, because we know that cells have a really big capacity for potassium, and there's some things that we can do. And it turns out that potassium movement into cells, again, through sodium potassium ATPase, is augmented and mediated by insulin and by beta agonist activity on beta receptors. And so that's the reason that giving insulin is part of our emergency pathway for patients who have hyperkalemia. If you give insulin, it will promote the movement of potassium into cells. We always give insulin and dextrose at the same time, because if you give somebody insulin, you're going to create a second problem. They'll just make them hypoglycemic. That's no good. So you got to give them dextrose at the same time. So everybody has a set of protocols set up in their emergency pathways, but that's the physiology behind it and why it works well. It's really probably the most effective tool that we have for potassium translocation back into cells. You can give beta agonists. You can give albuterol, for example, as a neb, and it actually will push potassium into cells. It's pretty reasonable. It works relatively quickly. I find it a little harder to control. You're not quite sure how much of the dose is actually going to the kid, and it will work. Cause a little bit of tachycardia. You're already worried about arrhythmia, so it sometimes makes me a little bit nervous, but it is effective. Since metabolic acidosis can cause potassium to come out, one of the big questions is, can we give bicarbonate to push potassium back in? It appears not to be as effective as the other two maneuvers. And every now and then it will cause a different set of problems too, especially if your patient happens to have renal failure and they've been metabolically acidotic for a long period of time. They might also, in the setting of renal failure, have hypokalemia, which puts them at greater risk for the arrhythmias, because we were talking about the calcium-potassium relationship beforehand. But if you give bicarbonate to somebody who's very hypokalemic, weirdly, you can drop their ionized calcium very abruptly, having to do with where protons get buffered on albumin and how calcium will go back onto that. So you don't want to add problems. So my recommendation, even though bicarb seems to make so much sense, is my opinion is that insulin and dextrose is really number one, followed by beta agonists if you think you need it to shift potassium into cells, And base replacement kind of, I think, fits in a little bit later on down the pathway when you've established what's going on with the patient a little bit more, and maybe their renal dysfunction and their acidosis is part of what's causing a longer term problem. So I think those are, at the time that we're trying to deal with the calcium infusion and making sure the heart stays safe, I think we're also trying to move potassium away from the heart membrane by shoving it into cells.
All right, so I'm going to ask some more controversial questions. So, do we use K-Xylate in kids, or is K-Xylate sort of falling out of favor in general? Not K-Xylate, sodium polystyrene sulfonate, because of a lot of discussions about colonic necrosis. And then I think we have a couple of newer kids on the block, like Pritimer and some other things too. Can you talk a little bit about that?
Yeah, it's really interesting. You know, I being incredibly old, I've been giving sodium polystyrene sulfonate for a couple of decades now, and it really does seem to work. It was never really tested very well. There was no formal studies that were done. I think it was invented in the 50s. I'm not quite that old, but so it's just been around, and people have just been using it, and it always seemed to help. It's slow. So again, if you think about the steps that you're going to be using to take care of your patient very acutely, if you're worried your patient has a heart problem now, you must make their heart membrane safer. That's where the calcium comes in. If you're worried they're at risk for a heart problem now, you need to shove some of the potassium into cells, recognizing the potassium is going to leak out. None of those maneuvers, although they're temporizing maneuvers, none of them actually make the potassium leave the patient's body. And if you think your patient is potassium overloaded, you got to get it out of them. And so one way to do that is to use their gut and ask that to help. And sodium polystyrene sulfonate is what we've been using for a very long time. It's a binding resin. It goes into the gut. It's like this sort of big sticky thing where there's a binding site for potassium, and it tends to grab all the potassium in the bowel, but it also tends to pull some out of the bloodstream as well. And then everybody poops it out, and hopefully things get better. But it takes hours to work. That's a 6 to 12 hour phenomenon to try to make that stuff get better. But you bring up some really good points, is that, first of all, does it really work? It was never formally tested. And is it bad for a person's intestine, particularly a really young person? And the answer is it probably is. And we've given sodium polystyrene sulfonate as something you have to drink. Tastes terrible. We've given it as enemas. It works that way too. Probably not so good for somebody's intestine, though, if they're really at risk. And the people who seem to be at greatest risk are the youngest children. So we don't recommend it for infants and for really little kids. And that's hard because it seemed to work, and we really wanted to use every tool that we had at our disposal to augment losses through the bowel. You're right. There are a couple of new kids that are on the block. One of them is Pediatric. That's an interesting drug. It's a binding resin, but the counterion is calcium. It's not sodium. So that's kind of nice if you think about it, because maybe it'll make the calcium go up a tiny little bit as that gets absorbed. You're also not giving a sodium load to somebody who just might have renal failure, and maybe you don't want to give a whole bunch of... That's a problem with my dialysis patients who misbehave, and I've been giving sodium polystyrene sulfonate, and then I realized I was giving them a sodium load, and that may not be the best thing if you already have renal dysfunction. So Pediatric has been well tested, approved for use in adults, and now I think for children as well. So has full FDA approval at this point, and to the best of my knowledge, and seems to work, but again, not quickly. And one of the questions is it really only good for chronic management for patients who have problems with excretion? Should it really be part of the acute management? It's second and third line in the acute management. If your patient is with it and can eat some Pediatric while you're also doing all the other things, that'll help you down the road. Because when you push the potassium into cells with insulin and dextrose and maybe with beta agonists, a few hours later, it's going to wear off and it's going to leak back out. But if during those same hours, you are augmenting intestinal losses, maybe things are going to balance the way that you want them to. The other new kid on the block is sodium zirconium cyclosilicate. That's a mouthful. So that sodium is the counterion there. So that is a little bit of a sodium load. Also works really pretty well, but also slow. So anytime you're using the bowel as part of your excretion mechanism, it's for what you want to have happening 6, 12, 24 hours from now. It's not really helping your patient right now. And if you're worried right now, there are other things that you need to do. the main way that potassium leaves the body is through the kidney, right? So if it turns out that you've still got kidney function, take advantage of that. And so big doses of furosemide are very reasonable. And I big doses, right? The bigger the dose of furosemide, the more likely you're going to respond. So yeah, they might be furosemide naive, and you might be a little bit worried that you over-diurese the patient. Usually that means we're going to make them too volume deplete. You know what? Volume expand your patient. We've got closets and closets full of saline intravenous. Just give it. And if your patient showed up volume deplete, that's part of the problem anyway, right? So you need to volume expand the patient, and then you can give them a big dose of furosemide, and then you could give even more volume if you need to keep up with those urinary losses, because that will augment the renal excretion. What's a big dose? I'd probably give 1 per kilo in a kid who's got what I think would be normal renal function. And one of my patients with mildly reduced renal capability, I'd give at least 2 per kilo. Don't play games. And if they pee more than you expected, just give more saline. It's easy. It's cheap. Putting stuff in is easy. Getting it out is the hard part.
Jordan, can you settle this debate of would you ever use lactated ringers instead for less of a chloremic acidic fluid? Like, does the 4 milliequivalents of potassium matter in LR?
That's a super good question. So can I solve this debate? The answer is no, because this debate will rage forever. And so no, I can't. But your point is really, really well taken, right? Is that volume expansion should be done with isotonic crystalloid. And the 2 main ones that we have available on the shelf, because they're cheap and they're around, are normal saline and lactated ringers. There's Plasmolite too, but it's a little bit more expensive. Most emergency departments don't have it hanging around. Probably works. And you're right, lactated ringers has the advantage of being a little bit more balanced and having some base in it because it's got lactate, but it's also got some potassium in it, right? It's got 4 milliequivalents to the liter of potassium. And you could argue there's no reason, you want to be in a negative potassium balance. Why would you want to add any in? If you're, this patient, I think you said was a 9-month-old. So I don't know what this kiddo's going to weigh, maybe 10 kilos, let's just say, just to make the math really, really easy. So 20 per kilo of normal saline would be 200 mils of normal saline, or 200 mils of lactated ringers. If it's 4 milliequivalents per liter, 200 mils is 1/5 of a liter, or 0.2. So that's, 40 milliequivalents that you've just added to the patient. Is that a lot? Probably not compared to their whole blood volume. But if I know that the patient is truly hyperkalemic, and that's the thing I'm really worried about, I would probably err on the side of normal saline, because I'd be more interested in excretion than I would be about taking advantage of lactate as a base delivery. And that is a personal opinion. I don't have any science to back it up.
It's great. That's why we have you on. We want to hear these expert opinions, your personal opinions. So that's great.
Can I ask another practical question? So we talked about, hey, when they're coming in and we're trying to get rid of the potassium, we're either going to do it, obviously we're going to stabilize, as we talked about, but we're either going to get through the kidney or the gut, maybe even both. 1 per kilo of furosemide when you're talking about someone with normal kidney function, maybe 2 per kilo with abnormal kidney function, and also obviously make sure your volume's good. For the potassium binders of the stool, how often should we be giving that? Is that something that we should just constantly be giving, like 3 times a day? Do you give 1 dose and wait for the next day? Like, how are we doing that? How are we kind of dosing and giving those medicines?
Yeah, it's a good question. I don't have as much experience with patiromer or sodium zirconium cyclosilicate that I really feel like I've got a feel for how to use it. I'll tell you how I used sodium polystyrene sulfonate, and then we'll go to the formulary and look it up, because you got more time for it, because it's right. You've done all your stabilization and emergency management, and you can go, take a look at the formulary and learn a little something about the other medications. So how did I use sodium polystyrene sulfonate? I would, if the patient can tolerate something into their gut, I'd give them a dose whenever I thought I could get it into them, because I know it's going to be working over the next 6 to 12 hours. So in the acute setting, what I would probably think is that a patient like the one that we've described at the top of this session, this patient's going to be in the hospital. So we know that we're going to do our acute management. Maybe we'll give one enteral dose if we feel that it's safe, and then that patient's probably going to get lab checks again, maybe 4 hours later, maybe 6 hours if we're really feeling good about things, maybe 2 hours later if we're still trying to figure out where we are, and then probably again the next morning. And then you'll have a better idea of where you are, and you can decide if you need to use the enteral drugs again or if maybe you're done.
And I think I have probably the last question about acute management. We have kind of walked through all these processes here. And this is kind of going back to that initial point in the emergency room. So when we get, for example, that potassium back at 7.5, we talked about some tests that we might want to send. Where do you draw the line between we don't have time to wait for these tests and we should start all these management questions, or we should wait till the repeat BMP comes back? We should wait till we get some urine in this patient, by giving them a bolus and then getting that urinalysis and all those things. How do you balance that? And are there any recommendations you'd give to our listeners to try to walk through that piece?
Yeah, I think that's a really hard question. And it's hard because, you have to make judgments sometimes sort of on the fly while you're right there. So I think that that's tough. I would, if that potassium comes back at 7.9 or 8.1, and like your case, this patient, it was 7.5, which is pretty high. And I know the patient also has a metabolic acidosis. I'm worried has some sort of other illness going on. I suppose it's possible it's an acute, gastroenteritis, just got really, really volume deplete and a little bit of water replacement in the interval. But I'm more worried something else is going on. So in that situation, while we're drawing the repeat tests, I probably would want to secure vascular access. And I might have a very low and get an electrocardiogram. And certainly if I had any concerns on that electrocardiogram, as much as I know that intravenous calcium has some risks associated with it, and placing an IV in a little person, you're never 100% sure it's in good position. I might err on the side of giving some calcium gluconate at that point just to try to get things a little bit more stabilized, and also try a maneuver to shift potassium into cells. So that might be my insulin dextrose approach. It might be my beta agonist approach. And then I can also, while labs are cooking, repeats are cooking. If the 7.5 was a little bit hemolyzed and it turns out it was actually, 6.2, and we dropped it down to 4.3 by shifting it into cells, that's better than letting it rise and letting the patient have an arrhythmia. Urine, not everybody's going to give you urine because they're going to be volume deplete and they're going to be sick. You know what? If you get the urine an hour or 2 or 5 later, it's okay. We'll get at least a little bit of a hint about what's going on. And if we absolutely can't figure it out, right, the urine potassium is high because you already gave the furosemide and they're already starting to pee and it's an augmented urine output, that's okay. If everything gets better, that's what we really care about, right? And if you can't always figure it out. If later on things are still a problem, you have to dig more deeply. And then you'll be doing more testing to try to understand what's happening. So I think those are choices that you sort of make in the moment, have the appropriate level of concern about an abnormal electrocardiogram. And I think that's the major driver. If the electrocardiogram is rock normal and you are completely supremely confident of that, you got a little more time.
I think the last question on this is, it sounds like you're actually going to do CKD as a whole other section, but I think we maybe have time to talk briefly about how that fits into the acute management. So it sounds like acutely, if a patient with CKD comes in, you're doing all the same things in the beginning, but you might tolerate a higher potassium, so you could wait while you consult nephrology.
I think it's very reasonable. If you know your patient has chronic kidney disease, the glomerular filtration rate is a little bit low. You have, maybe he's one of our patients in our system. You're familiar. You can look in the electronic health record. You realize this patient's been hanging out at, 5.8 to 5.9 for the last year, and it comes back at 6.5. Completely asymptomatic. Everything is okay. No palpitations, no weakness. You want to get an electrocardiogram? Do it. Never a downside in getting an electrocardiogram. And then you would be able to take a step back and say, I think we've got some time and I can call my nephrology friends and I can kind of regroup there.
All right, awesome. So thank you so much, Jordan. That was a fantastic summary of really acute management from top to bottom. Angela, Chris, do you guys have any other questions you want to ask?
No, I just think yeah, I think this really helps me the next time I have that critical lab come back in the emergency department or in the hospital on nights, of course, or what have you. We've done a lot of like signposting summary throughout this, but I'm wondering if you have any big take-home points for our listeners, big picture summary before we move on.
Yeah, I think from the standpoint of acute management of hyperkalemia, the most important thing to remember is my patient at risk or are they not? And what makes us worry that your patient's at risk is their cardiac status at risk. So low thresholds to check electrocardiogram. High index of concern if the potassium is really elevated. Always err on the side of your patient's safety. And if you're worried about those things, yeah, there's a lot of other assessment that we can do. Yeah, there's a lot of other management that we can do. But right then and there, you got to keep your patient safe. So I think the most important thing to remember is if I'm worried about my patient's heart, let me give some calcium infusion because that will help keep my patient's heart safe and limit the risk of arrhythmia and do some maneuvers that will shift potassium into cells and acutely bring the level down in the bloodstream. And once you've done those two things, then you've got some more time to think. And having more time to think is a good thing to do.
All right, everybody, stay tuned for chronic kidney disease and hyperkalemia.
All right, y'all, this has been another episode of the Cribsiders.
It's for the kids.
It's for the kids.
Get show notes and sign up for a weekly... A little delay, but better late than never. Get show notes and sign up for a weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or contact us at thecribsiders@gmail.com. Special thanks to our producer for this episode, Angela Wizang, our showrunner, Sam Mazer. Whoops, that's me, sorry. And our wonderful social media team on Twitter, Instagram, and Facebook. I have been Sam Mazer.
I've been Angela Wizang.
And this has been Chris the Chew Man Chew. Thank you and good night. And for those who made it to the end, guess what? You'll have to wait till part 2 to hear that poem written by AI. See you guys.